Aloha and welcome to Conversations at HMA. My name is Mark Alexander, Executive Director of the Hawaii Medical Association. Thank you all for joining us for this evening's program, which features discussions with physicians and other thought leaders in the healthcare arena. This evening, we're having a members-only session introducing Zipnosis, cutting-edge technology for asynchronous telemedicine. I'll introduce our presenters shortly, Matt Hodges and Will Galach. The format for tonight. We're going to have an introduction and overview by our guests that will be approximately 20 minutes, followed by an actual demonstration of Zipnosis in action, which will then be around 20 minutes. Then we'll open up for questions, discussion, etc. Since this is a members-only gathering, we're using regular Zoom, so please type your questions, comments, suggestions, ideas in Zoom's chat function. Feel free to type in your questions and comments along the way, and we'll try to get to them after the main presentation and the demonstration. There's something really critical along the way. I believe Vicky Shaw, who's also joining us from Zipnosis, will monitor so that we can address those. We ask you to please keep your microphone on mute, especially during the presentation and demo. Once we open up for questions, we'll go to the chat first, and then if people wish to speak, we ask you to please use the Zoom raise your hand feature, and we will call on you in order. We will end our program promptly at 6:30 p.m. The program is being recorded and will be made available to members on our HMA YouTube channel in the private section. We want to hear from you, so please email info@hawaiimedicalassociation.org or contact us via our website or my work email address as well, of course. It's now my pleasure to introduce our main presenters. First is Matt Hodges, Associate VP of Marketing for Zipnosis. Matt is a passionate leader who's transforming healthcare by addressing patient access, acquisition, leakage, equity, and provider experience through over 20 years of marketing. Matt brings a breadth of perspective with a cross-industry background that spans HR, recruiting, e-commerce, behavioral health, product development, and telemedicine. Also joining us is Will Galach, Business Development Associate for Zipnosis. Will is driven by the thought of improving care experiences for both patients and providers. In this spirit, he has spent his last 3 years at Zipnosis listening to provider groups, educating them on Zipnosis's unique approach to virtual care and solving for their needs. He often does this through showing off the Zipnosis platform via demos, which you will all see tonight. Without further ado, we turn things now over to Matt to get us started. Mahalo.
Awesome, thank you. Let's get this screen shared and we will get moving. Well, thank you everybody for your time today. So when you think about Zipnosis and asynchronous, the best way I like to describe it is that we're really prioritizing the only two people that matter in healthcare, and that's patients and providers. And in terms of asynchronous, it's really defined as two related events happening at different times. But our unique flavor of it goes well beyond that, and we'll talk more about it. This is kind of the obligatory logo wall, but the big thing to keep in mind here is that we've been at this for almost 14 years now. We've at scale done, it's actually about 4.5 million encounters on our platform, a net promoter score of 64 from patients. And a net promoter score, if you're not familiar with it, anything over a 0 is great. When you're up in the 64 realm, it is closer to really leading consumer brands that you would see out there like Disney or Starbucks. And then across that time, we've had 3,500 physicians leverage our platform. So we're tried and true technology that just is the best kept secret in healthcare. And we've also been validated at scale too. So Baylor Scott & White has been a customer of ours for quite some time. They did an efficacy study comparing patients being seen through Zipnosis versus face-to-face encounters for primary care. The net result of it, we can get you a copy of the study after this, but is that they're equally effective, and there's no drop off in the quality of care when leveraging our platform for low acuity conditions. So when you consider us and look at our primary customers, they are health systems, and they leverage us for a number of reasons. One of the main reasons they come to us is for our digital front door approach. And that is just basically means that we triage patients and get them to the right point of care at the right time, and treat those that are appropriate to be treated through virtual care. We actually coined the phrase digital front door and trademarked it years ago. So we definitely were pioneers in that area as well. The power of what a digital front door does is pretty incredible. At the peak of COVID in 2020, you saw Zoom, Microsoft Teams, Amwell, Teladoc, all the big video platforms out there that people started leveraging or had been traditionally leveraging were falling over because of the demand that was hitting them. And wait times are going to 24 hours plus. We saw almost a 12x increase in volume in that kind of February, March range of 2020. Our wait time only increased 6 minutes for patients. And the average for us historically is 8 minutes, 8 to 9 minutes. We saved about 2.1 million minutes of physician time and diverted that time to patients that needed it most. A great example is Washington State was one of the first to really experience COVID and scale and volume, and kind of crushed the health systems out there. One of our partners wisely really injected us in front to help divert patients to the right point of care and keep those that really just had a cough, cold, or flu from coming in unless they got more severe. And we had one physician at that health system that did 1,000 visits in a week on our platform, which is just incredible. But it saved tons of times for the physicians that needed to sit and really work and help treat patients in person. And we also diverted 176,000 patients to the right point of care without any clinical or administrative staff in order to make that happen. And from that standpoint, the digital front door not only saves time and manufactures at scale, but we also are an excellent acquisition and what I like to say reacquisition tool, because if you increase the ease of access, patients tend to come back to that point of care. And we had a study done by Carrot Health, it's now owned by Optum, so third party. And 40% of the patients that came in on our platform were discovered to be net new patients of the health system. They generated about $2,900 in downstream revenue in the first year, and they were 276% more likely to convert to a health system patient. So it's not only efficiency, but it makes good business sense for basically being that kind of pillar of care in a community for a health system. When you get down to the physician level, though, I think that's where we really become exciting. And I like to look at this through the iron triangle or the law of triple constraints, which is used a lot in evaluating products. And typically everybody will say good, fast, or cheap. Pick two. You can't have three. And what we do sits squarely in this realm of the impossible. Whereas traditional healthcare, even if you're using video, is quality care, but it's slow and it's at a high cost because it's really difficult to create those efficiencies. Our approach leverages adaptive interviews that put asynchronous on rails, so it goes well beyond what email would be and puts it into a structured format, and Will show you that here in a little bit, so you can grasp kind of what we do uniquely there. But what we do is allow physicians to practice at the top of their licensure. And what I mean by that is that we strip out 99% of the administrative work for low acuity visits, and we can treat 400 plus diagnosis through the platform asynchronously. When you step up to synchronous or video, chat, or phone, which we also support, it's 600 plus. And it's 10 times faster than in clinic or video. and there's 90% adherence to clinical guidelines for antibiotic stewardship. One of the early adopters of our platform in Alabama really kind of said it best. We must learn to use asynchronous, which is really a force multiplier in order to make sure those who need to be seen get seen. And I think that's a critical point, whether you're living in a fee-for-service world, or living in a value-based care world, or some hybrid in between there. We have a lot of value in both scenarios. But at the physician level, and I like to look at this through the lens of primary care, I've talked to a lot of health systems, and I've talked to provider groups around the country, and there's this startling stat that comes out that says 29% of the visits go unused due to cancellations or no-shows. And because of the way those visits have to get scheduled, you can't really backfill them easily on the day of. And that amounts to about 1.5 hours of capacity per day that maybe isn't utilized. Now, I've talked to some groups that say, well, maybe it's closer to 15 or 20%. And I had one doctor who prided himself and said, well, ours is like 6%. But the key point that I'm trying to make here is that you can take a sliver of that time and just spread out 15 minutes throughout your day and pick up a visit here or there coming in the queue. And you can increase capacity for a single physician by 60%. And if you're just charging $25 for an async visit because it's that much more efficient, you can increase revenue by $64,000 on visits you wouldn't be getting anyway. And in primary care, for example, that might mean they're going to an urgent care clinic, or even worse, to an emergency department when it's not well suited for what their needs are. And so from a value-based care perspective, if you offload low acuity visits to Zipnosis, what happens is you basically manufacture 15 minutes, because they average for a visit based on JAMA and a couple of other sources is about 18 minutes, including documentation. So we will basically take 89 seconds to complete a visit on our platform. And that means there's 15 minutes that's saved. You do that 100 times, creates 1,500 minutes saved per month, divide that by 30, and you create 50 complex visit slots by doing that. And so I think in a state like Hawaii, and Mark has kind of shared with us, it's clear everywhere in the country that there's kind of a staffing crisis. Physicians are getting burned out, but Hawaii is in a unique position where there's an even larger physician shortage. So I think that's where asynchronous can really be a powerful tool in the state. And for patients, it's actually great too, because as I mentioned, if you're doing it 10 times faster, you can actually bring the cost down. Our average for customers that leverage our platform is somewhere around $25 to $40 for an async visit. But we save a patient roughly $137 over maybe going to an urgent care clinic or emergency department. So this number on the right is really a blended cost structure. But more than anything, consumers love it. I read this every time. Everybody on my team probably gets sick of me reading it, but I was kind of blown away by it. We got a little bit closer to patients when we started serving payers. And so we got reviews that started coming in our consumer branded example of what Zipnosis is. And this lady actually sought us out in social media and somehow got an email for our development team and wrote volumes in both channels. And it was different content, but this one paragraph really kind of bakes down the value of what we do at the patient level. I'd like to say to whomever is the person who made the app or takes feedback, as a rare disease patient, thank you so much. I have never seen this sort of care before, and I can't tell you how much I appreciate the simple platform and how easy it is to get care and treatment plans within seconds without scheduling hours out of my already packed day to get something as simple as a cream. I can't tell you how grateful I am that someone finally came up with something so genuinely thoughtful. And so qualitatively, that I think everybody in our company just grinned ear to ear, because we knew it, but we've never been this close to patients sharing their story. And I think the thoughtful aspect of what she said implies empathy that we baked into something you might at a distance think is cold because you don't see a patient face to face. But because of how convenient it is, and how fast patients can be treated, it hits another sector of what's important to them, which is speed and convenience in getting care. You can go look at that brand. It's called DocSquad. Again, primarily serves payers, but there's ratings on the iOS store and the Google store that averages 4.9 out of 5 stars, and the reviews all kind of echo this storyline, which is pretty fantastic. And so without further ado, I will be quiet and let Will show off all that Zipnosis does well.
Cool. Awesome. Great. So I'm going to share my screen here. Can someone confirm that you are able to see this?
Good to go.
Okay. Thanks, Matt. I appreciate it. Good stuff. Okay. Great. Like Mark introduced earlier, my name's Will, and really my job here at Zipnosis is to demonstrate and highlight all the great work that our clinical team do and our product and engineering team do. And so the primary form of that is through demonstrations. And it really brings kind of like everything that Matt just said to life when you actually see what our capabilities are for both patients and providers. And so what you're looking at here is a demo site that I've created, and I'll run through, showing both the patient and provider experience for today. I'm going to be navigating throughout a couple different tabs. So this is a typical landing page that we stand up individual to each one of our customers. So those could be small provider groups, 1 or 2 providers, all the way up to multi-state health systems. We kind of span the full gamut, if you will. We stand up a unique white labeled site. So this is customized per our customers' branding, messaging, look and feel, all that good stuff on a customer by customer basis. I'll be navigating kind of throughout these various tabs here. And so this is a typical landing page, which I just described. Then we have a patient account. So the patient here today is Tad Dockendorf. And then we have a provider account here. And what I'm going to do here, I like to start off with the provider side for provider organizations such as HMA. And so what I'm going to set up right away is, what does the provider experience look like for these asynchronous visits? And so before I actually jump into the encounter, just envision with me what this looks like up until this point. So a patient came in, indicated that they're here for care. They went through what we're going to call an asynchronous visit, and they sent it off to a provider who's staffing this platform. I'll show that in just a second, but that's what's led up to this provider experience that you're about ready to see. And so here we have one of the providers who's staffed on this platform, this Ayurveda Health demo site. What you can see here is the provider has their queue, their active queue of visits. And so down here below this basically indicates what visits are ready for review. And so you see that this provider has 1 patient in the queue, Tad Dockendorf, 47-year-old male, suspected for a pink eye visit, and he's been in the queue for about 20 minutes. What I'm going to do as the provider is I'm going to pick up this visit. So I'm going to claim the visit and jump into this encounter. What we're going to do right out of the bat is make sure that the provider understands who they're issuing care for today. And so what you see at the top is demographic information around this patient. You see this patient's name, Tad Dockendorf, sex, age, reason for a visit, this patient's time in the queue, this patient's language, status of the visit, all of that good information, demographic information around this patient. What you also see is the provider has the ability to look at previous activity on the platform. So this is a frequent user of the platform as my demo patient, has visited many times over. But the provider can understand, why has this patient been seen before and what have been the results of those visits. As I scroll down here within this asynchronous visit, the provider will next see a visit summary. And so what I'm highlighting here currently is a nice visit summary note that's automatically produced by our system, the Zipnosis asynchronous clinical platform. What this shows, as the providers either on the call or in the recording can tell, is this is a nice detailed note around this specific patient's condition today. And so what you see is we've stitched together all the necessary details about the patient's condition into this summary. Patients here for suspected conjunctivitis, here are the symptom details, here are the precipitating events, here's the pertinent medical history. All of that good information is stitched together automatically into this visit summary note. So the provider can quite literally review this in a matter of paragraphs, and it takes seconds. When necessary, given the patient's condition, uploaded images may be viewable here too. You can see pink eye, a couple images have been uploaded. Provider can check those out. And then the provider will continue to work down in this visit. Next kind of module that they'll work through is medications and allergies. So we'll collect patient-reported medications. The patient attested to taking Advil and Propecia, and as well as patient-reported allergies. And so there's been no allergies to date. Kind of a cool thing for our provider partners is we've done some work behind the scenes integrating with a company called SureScripts, who manages a huge pharmacy network. And so we'll automatically pull 2 years of medication history on patients as well. And so in this case, the patient didn't report taking amitriptyline, but we'll catch that via that SureScripts integration. Providers always get excited about this due to the quality assurance that we provide to them. Again, the idea here is we're painting that picture asynchronously of who this patient is, why they've come to the platform, and what's their background information. The cool part about this is this will all be asynchronous. Dr. Shirasa said this earlier when we were talking kind of about asynchronous care versus synchronous care. We blend the two together. And so this will be an asynchronous visit, but what we're able to do for providers is allow them to convert the visit into synchronous communication methods. It's called what we call synchronous modalities. And so if I were to click this module here, the synchronous step up, the provider would be able to convert the visit into a synchronous form of communication. Maybe that's chat, maybe that's phone, maybe that's video. One of the differentiators that we kind of have as a technology platform is allowing your providers to connect with patients in different ways, asynchronously as well as synchronously in terms of chat, phone, video. I'm going to keep this async in this case, so I'm going to close this module and I'm going to continue down into diagnosis and treatment for this visit tonight. What we're going to get into at the final part of this provider experience is diagnosis and treatment. And so what you see highlighted on the right here will be the treatment plan note that's sent back to the patient. You can see at this point, it's just kind of boilerplate, but we'll build out this note with a lot of automation driven by our clinical team. So provider gets down to this point and is issuing an assessment. Due to the fact that we collected clinical information on the patient, our clinical team can kind of populate common occurrences for assessments up top, or the provider could write their own diagnosis and treatment plan if they choose to. In this case, I'll say, hey, this is clear-cut like bacterial conjunctivitis. And as you'll see in just a second, I'll select that assessment, and in one click, we'll automate a lot of work within this note on the right. So I'm going to click bacterial conjunctivitis as the assessment, and one selection on the left produces this clinical note that'll go back to TAD. So this details, hey, the assessment's bacterial conjunctivitis, here's the self-care instructions, here's when to seek care, all of that good information that follows best practice guidelines produced by our clinical team. The cool part about this too is we can use that clinical logic, that clinical engine that we've built to help guide the provider to smart clinical decisions. So in this case, bacterial conjunctivitis, obviously the concern is antibiotic stewardship. We take the literature that suggests that if the patient attests to any of the following highlighted here, antibiotics could be appropriate. We trigger that, hey, one of those were suggested by the patient. We'll green light that antibiotics could be appropriate. Provider continues down into RX medications. We'll automatically pull the formulary information, which you see here. and provider can pick a potential prescription to send back to this patient. So I'll click Polytrim on the left here. That's my second click on the provider side. And this is a fully functional note that'll be sent back to the patient. Here's the patient assessments, conjunctivitis. Here's the medication information, when to seek care, and the prescription's actually attached to this visit, and it'll be sent back to the patient to fulfill. If the provider had additional notes, they could follow up with them here, add them to that note that's sent back to TAD the patient. They can detail follow-up care instructions outside of our templated material. They can even issue promo codes or assign school or work notes. Kind of going back to some math here that Matt suggested, the average clinical work time for these asynchronous visits across the 4.5 million encounters is 89 seconds. So less than a minute and a half from the time in which the provider jumps into this visit to issuing care back to the patient is less than a minute and a half. It really shows kind of the power of what we've built from a technology and clinical standpoint. So I'm going to go ahead as the provider again, send this off to the patient. So that's sent off to the patient. Me as the provider continues to work my queue. I can continue with rounds in person, waiting for the next visit to come in. What I'm going to do now is transition into the patient side of things. So I'm going to tab over here, track with me to the patient dashboard, and I'll show that fulfillment of that prescription. So the patient will get an email, text notification saying, hey, that provider response is available. You can view this treatment plan. So TAD here can view this provider response. And this is that treatment plan that was produced by TAD. So here is the assessment for bacterial conjunctivitis. Here's the medication information, all those instructions. And you see at the bottom that TAD has action required, choosing his pharmacy. So I'll go ahead and click choose pharmacy here. I will do some cool geolocation to where the patient's present at the moment. This patient's technically out of Cheyenne, Wyoming. So I'll pick a pharmacy nearby, click once, click twice, and the patient has successfully fulfilled this prescription at a nearby pharmacy for them to pick up later in the day. So I'm going to stop right there. Just kind of summarize what you just saw is the provider picked up a visit, an asynchronous visit, jumped in, and in 89 seconds issued an assessment, a diagnosis, a treatment plan, and a prescription that's sent back to the patient to then fulfill. So the next question is like, how do the patients work their way through these asynchronous visits? And that's what I'll show on the back end of this demo. So what you'll see here is Tad Dockendorf's patient dashboard. So you just saw that he picked up an active visit. Now that visit's done, so you don't see any active visits. What I'm going to do here is actually kick off a new visit for Tad. So I'm going to start a visit, and I'm going to pass through some quick terms of service, informed consent, attest to my current state of location. Yep, go ahead.
Yeah, I just wanted to see if Dr. Christensen or Dr. Shirasu had any questions on, kind of what they've seen so far. I love having a couple of physicians in the room always. So.
I'll wait to the end of the presentation and then ask some questions.
Okay, sounds good.
Okay, I'll forge ahead. So here, patient kicking off an asynchronous visit or a visit. Continuing on here, attesting to this not being an emergency situation, passing through, and then they're going to get to this starting point. At this point, our platform asks why they're here for care today. So what's the reason for a visit? Do note for kind of the different specialties who are on the call or listening to this recording, I clicked into specifically urgent care. There's other clinical protocols that we can enable in different clinical service lines. But for the sake of this demo, I'm kind of keeping it to urgent care, and thus the initial chief complaints in which you'll see on the screen now apply to that urgent care setting. So here the patient attests to why they're here for care. What's the reason for the visit? And so I'm going to show off a couple of these. The idea here is our clinical teams built out a wide range of what we call initial chief complaints. for the patient to attest to and start on their care journey for. I'm showing a couple of these. We work with each one of our health system customers or our provider partners to determine what types of care they want to issue, and thus will enable or disable these various initial chief complaints based on what clinical conditions they want to serve.
Yeah, and one thing to always keep in mind with us is that this is not AI, it's true like hand curated branching logic built by physicians on our clinical team, as well as their nurse informaticists. And then we've got a clinical quality advisory council of 18 chief medical officers and some of their staff that also review and provide input that help us to continue kind of crowdsource and improve what we do on a regular basis.
Yeah, it's awesome. It's all rooted in clinical best practice guidelines. And so what I'm going to do for the sake of this demo is say, hey, the patient's here for a suspected eye, ear, mouth problem. We'll go down and click a suspected pink eye. So redness, irritation, drainage of the eye. We'll go ahead and select that as my reason for a visit. The next kind of prompt we'll ask the patient is, how do you want to conduct this visit today? And so again, I spoke to this earlier on the provider side, but we kind of offer those 4 different modes or modalities of communication. And our customers can decide to unleash those to their patients as they wish. And so what you see as options to the patient for this demo site is the asynchronous intelligent interview on the left here. You could jump right into a video visit here, a live chat visit. And we also have actually that phone modality for direct phone calls from patient to provider as well. That's omitted on this one because pink eye, obviously, like there's a visual nature to that condition. But again, it's giving patients choice on the patient side of things. And so what I'll click into here is that asynchronous visit. An important stat on this screen is our data analysis over time in terms of patient preference across these modes of communication heavily favors the asynchronous visits. It's about 75 to 80% of patients choose the path of these asynchronous intelligent interviews when given the choice. A lot of our customers price lower. They can get to these visits quicker and get patients the care they need faster. And it definitely reflects in terms of patients preferring these types of visits. So I'm going to go ahead and select that transition screen here, basically presenting the fact that, hey, Tad, the patient's about ready to start this interview. Takes about 7 minutes. Get ready to go. So I'll continue on here, and I'm actually within this interview now. And so the idea here is what our clinical team has done is taken that initial chief complaint in which the patient opted in for, and we've taken that chief complaint as well as adjacent conditions, and we've built out all the necessary questions with that clinical dynamic branching logic to ask all the necessary questions around this patient's condition today. And so if I'll start kind of working my way through this and you all can follow along. But the idea here is like we're kicking off this visit asynchronously. So when did my symptoms start? I'll say today. Symptoms in both eyes, I'll just say right eye. White part of the eye red. Yep, no drainage, no itchiness. We'll incorporate photos when appropriate to guide the patient through this. Again, kind of to Matt's point, like this is all grounded in actual clinical work that our clinical team does. And so there's a dynamic nature to this. I always stop and kind of show this as like when the patient is asked about a pimple-like bump on the eyelid and suggests, yes, there is one. The next couple of questions, we'll ask additional questions around that. So how many bumps are on the eyelid? Is the bump tender? It's collecting, it's kind of expanding and contracting to ask all necessary questions and thus collect all necessary information from the patient around their clinical condition. So I'll keep working through this for the clinical folks, the providers on the call. He'll be quite familiar with these types of questions because these are the medical best practice guidelines. It's pretty cool when we get providers on and they basically tell us how to walk our way through this, and it just maps out the questions that they'd ask on an in-person visit. is pretty special. Important to note here that all of this is like designed from a mobile standpoint, a mobile first standpoint. So we see a majority of our patients access via mobile devices. It's all designed from a product and engineering standpoint to be mobile first for patients to access. So I'm going to pass through the last couple questions here as I work my way through this asynchronous visit. Near the end of this, we're going to ask for those patient reported medications and allergies. So again, you saw this on the provider side where the patient had previously reported taking Advil and Propecia, sorry. They can add additional medications here, or they can just attest to the current meds that they've already stated. So I'll just attest to those current medications and work my way to current allergies. I'll say no allergies. Again, we'll reconcile some of this information with that SureScripts connection integration behind the scenes. Again, within some of these protocols, we'll ask for photo uploads. So the provider or the patient can stitch together a couple photos. In this case of the eye, they can also take a photo from their device. This will all be stitched together within that visit summary note that you saw on the provider side. One of the final things here is asking the patient how they prefer to be contacted if there's follow-up needed. And so this gets to those other modalities that we offer, the chat, phone, video, synchronous forms of communication. The patient will opt in for these three, and thus the provider could reach back out and connect with them via those means if necessary. And the last screen here is payment due. So a lion's share of our customers decide to charge as kind of a copay, out-of-pocket cash pay situation. That's reflected in this demo with the $25 cash pay collected at the time in which we ensure that the patient's going to be actually seen by the provider. So it's at the very end of this interview when the visit's going to be sent over to the provider, we're going to ask for payment. And so patient could upload a credit card, HSA debit card. There's also the ability to do some cool work with patient segmentation and group benefits. So maybe that's billing insurance, or maybe that's giving discounted care for internal employees and thus people on your health plan. We can kind of solution for some of that work within this workflow. In this case, I'll go ahead and just issue a promo code to cover the cost of this visit. And at this point, the visit's been sent over to the provider for review. And so this kind of full circle wraps up where we started. In this case, the patient would go back to their dashboard here. You'll see that, hey, their active visit is waiting on a provider response. And that provider in which I started the demo experience with would jump into the visit, issue asynchronous care, send that diagnosis, treatment plan, prescription back to the patient to then fulfill at their convenience. So with that, I will stop. Mark, Dr. Shirasa, I think Matt mentioned Dr. Christensen joined. Any questions during this live part of the webinar here?
Okay. I think that the physicians who belong to some health system, I'm not sure how, like I do. I belong to the Adventist health system, and I'm not sure how this would fit in with my practice. My patients belong to either HMA or Medicare, and how are my patients going to be even aware that this platform is available? You know,
that's a great question. I'm personally working with a number of primary care clinics because I'm pretty passionate about how we can help in that setting. And there's a physician group here in Chattanooga that I'm directly working with. And what they're finding, and they're an adult medicine practice, so they've got a blend of all age groups. is that they had a great example. We turned it on, made sure there was access on their website for it, but their first patient came in because they called in with a UTI, and they're like, hey, we don't have any appointments for 2 or 3 days, but if you want to get treated now, hop on our website, click the Get Care Now button, and we will get you taken care of probably in the next hour when a physician comes out of their next visit. And the patient was ecstatic. And the doctor picked up the phone after it was done and said, oh my gosh, this is incredible, because we never would have really been able to treat that person. We would have gone to an urgent care clinic.
Yeah. Okay, now 99.9% of my patients have some form of insurance, be it private, Medicare. How do they get involved? How do the patients pay this $25, and how do they get reimbursed by HMSA or the Medicare? I mean, they're not going to be willing to pay for $25 when they can be seen almost for minor, less copay by using their insurance.
Mm-hmm. Yep. So we do support revenue cycle management and support that side of it. So we can do insurance checks on the front side, pass along all the information for that revenue cycle management team to run things through for reimbursement as well.
Okay. And of that 25 that you charge the physician, that the patient, how much of it goes to the physician?
All of it.
All of it?
Yeah.
Okay. Then the next question is, how much would it cost for a physician to set up Zipnosis?
So we, as I was saying, we've traditionally served health systems, and so when we get deeper into big integrations, it changes the structure a good bit. But the long and short of it is that we've moved towards a bucket of visits pricing. So it really depends on what the volume of that clinic and what they can do, you're looking at somewhere between $5 and $7 per visit is basically what it would break down to, and for the clinical efficiencies you get with taking a 15-minute visit, taking all the documentation out of it, and turning into an 89-second visit, it's really an economical way for a physician to kind of expand their capacity.
Okay. It seems to me that perhaps you should be making this pitch to a health system with its panel of physicians and a panel of patients, rather than to individual physicians. Is that valid?
And the health systems are our traditional customers. We have just always found physicians are blown away by what we're capable of doing. And traditionally, we didn't even respond to folks that came through that were small practices. In the last 6 months, I took it upon myself to really start having conversations with them to understand what their needs were. And they're implementing them in their practices. We've got a lady that is doing about 25 visits a day on our platform, as an example, and she's been live for about 3 months. I think our first kind of really in the primary care setting. And when I say primary care setting at a clinic level, we've had health systems that like Baylor Scott and White that were doing it a long time ago. But so it's twofold. It's both.
The kind of follow-up question to one of the things Dr. Shirasu sort of brought up, and that is, you're now making this available to small clinics and kind of private practice, physicians and that. And I'm kind of curious. I know you share anecdotally how this one physician has found it extremely helpful. Can you share a little bit more about the patient demographic? Like what kind of patients? Like I would think, my gut would say, oh, this is going to be younger patients, but are you getting older patients?
Yeah.
What does the demographic look like? Thank you.
That's a great question. So the bulk of it will sit in the 20 to 50 range, but we definitely see, we actually had someone that was 100 that did a visit on our platform. And especially because we can step up into video and synchronous modalities like phone to ask additional questions, it really gives flexibility to go well beyond kind of your initial thoughts that only a young person would want to do it. So. And plus, if reimbursement is a concern, the stepping up to modalities like video support that as well. So instead of it being a pure async visit at 89 seconds, you step it up into video. It would be like a 5-minute visit. So you've cut it by 2/3, and versus 15 to 5 minutes if you're using an async into video. So.
So Dr. Christensen put her phone number in. I don't know if, not to put you on the spot, Vicki, but.
No, I'm grabbing it. No worries.
Okay. All right, good. Thank you so much.
You bet.
So Dr. Christensen, you're going to get a phone call soon. Okay. Dr. Shirasu, go ahead, please.
In other places where you have this system working, how does the patient's insurance now, medical insurance come into play? You gave the example where the patient paid $25 for that visit for the conjunctivitis. Now, why does he get any break from his insurance company? I didn't see anything in there about a insurance payment.
Yeah, we
Yeah.
call those zip groups, and for the insurers that a clinic, a health system supports, we do a lookup through Change Healthcare to find out what that patient's insurance plan is, and then pass that along, and then you can do again the reimbursement cycle on the backside. And there's lots of different ways that we can do it. We could charge the copay, you could do nothing and then charge it all on the backside even. So, well, I'll let you jump in there because you're better on the product front.
So
Yeah.
do you work with the insurance companies in the areas to get their blessing, or you don't have to do that?
Typically our customers with their existing relationships to the regional payers negotiate all that, Dr. Shirasu. To Matt's point, like some of our customers have decided that they'll offer these at $0 to the patient, and then we'll send that customer the necessary data to then send along to the payer to get paid downstream. It just depends on how the customer wants to set it up, but it's really kind of falls back on the customer, so kind of health system or provider group and their relationship with the payer and any negotiated agreements there that already exist. Does that answer your question?
Not really clearly, but you know that in Hawaii we have the major carrier is HMSA.
Yep.
And I would guess that most of the physicians are on par with HMSA, meaning we have signed an agreement with them that we would accept what they pay as the total cost for that patient's care. So
a value-based care relationship in that sense.
Okay, so
Or,
if the patient has HMSA, I'm not sure he's going to be willing to sign up or see a patient on this Zipnosis platform and pay $25.
Yeah. So then
He would say, I rather go see my doctor who will not charge me anything because HMSA will pay my entire cost, including the cost of the medication. If you were dealing with patients who had no insurance, then this would be perhaps a low-cost way of providing care to that person. But in Hawaii, I think, other than the homeless, most of them have some form of medical insurance.
Yeah,
So-
and we support that. So we support $0 and running through revenue cycle management just like you would in person in that case.
Yeah. So so it's still not clear to me how that patient that pays $25 is going to get
So
some money back from the insurance company.
yeah, so the demo example that I showed was just an example of like some customers decide to charge the patient $25, but in Hawaii, the people that signed up with Zipnosis could decide to charge $0 to the patient and then instead collect the money from the HMSA. Dr.
Ah.
Shirasu. Yep.
Okay.
So it was
okay.
just one example for the demo.
Yeah, pricing is purely dependent on how a clinic or health system or provider runs their business model.
Nice.
And we're flexible in revenue cycle management, getting payments from payers. We're flexible in doing cash pay. We're flexible in charging copays if that's what the plan allows for. So there's lots of ways that you can handle that.
Will, you mentioned that there are other physicians in Hawaii that do it this way or that way. Are you at liberty to tell me some of these physicians that are already in your program that I can say, oh, I just heard this presentation. Can I ask a few more questions from physician to physician?
Yeah, so what I didn't mean to misspeak there. I was kind of playing out the hypothetical of if we had a Hawaii provider group, Dr. Shirasu, then they could bill in that way. Currently, we do not have customers live in Hawaii.
Okay.
We have some in kind of
Mhm.
all along the Pacific coast of California, Oregon, Washington that you could speak to.
This is cutting edge, pretty cutting edge here in Hawaii, to even learn about this. So that's why we kind of kept this presentation to members only.
Yeah.
You're trying to respect that it is something new and different that's not present here. But Will and Matt and Vicky, if I can ask, so if there's some agreement worked out with, say, HMSA, and so when people log in and they identify their insurance, then it would automatically make whatever adjustment along the way when you get to the payment. Is that correct?
That's correct.
That's
Right.
correct. Yes.
Okay. So I think that would be the key. And can this be something that would be, appealing not just to the patient, and the provider, the healthcare provider, the physician in this case? Could it also be appealing to HMSA as well? And do you have insurance companies that say, "Hey, we really like this"?
Yep.
Will,
So the Doc Squad brand that I referenced that patient quote from in the presentation, that serves primarily payers. So it's the way we serve payers that want to deliver this to their member population.
Okay. So,
And along that line, do you have some kind of agreement with Medicare as to payment of your services?
So with Medicare, you would have to step up into video for virtually all those. The phone would actually work too, based on the regulations right now. But they treat it like a telemedicine visit at that point. So.
Okay.
good question. Yeah. Okay, folks, we are at 6:30. I have to say, Vicky, were you able to talk with Dr. Christensen?
I have her information and we will definitely connect. Thank you so much.
Okay, all right,
Yep.
okay. All right, well, what I want to do is I want to respect everyone's time. And, Dr. Shirasu, thank you for your questions. I think it was really helpful.
Yeah.
So I want to really thank Matt and Will and thank Vicky as well for representing Zipnosis and bringing this really cutting edge technology to the forefront of our attention here. I really appreciate everyone joining us for this edition of Conversations at HMA. We're experimenting with different formats and different kind of educational opportunities, and this is one of them. And so thank you. We know you have your choice of evening activities or night activities in the case of those from the continent. So thank you for spending time with us. This recording will be available to members by the end of this month. Thank you again, Dr. Shirasu, Dr. Christensen, and others for being members of HMA, where we are certainly committed to raising physician voices and supporting their care of patients and community, which is why we thought this product would be interesting. So again, thank you all very much. Mahalo and good evening.